My second part of my talk is about when I got from Michelle the email. One thing it said is, correct me if I'm wrong, Michelle, abnormal uterine bleeding. How do we prevent referring, reduce the number of referral? Very important question, and clinical pathways. So I brought Alison with me, Alison Davenport, who is one of our sisters in gynecology, and she's just become the nurse hysteroscopist, first in Barnsley. So, well done, Alison. Okay, so she looks after and supports us in a lot about abnormal uterine bleeding, the whole spectrum. So we thought we'll start having a look at some of the issues that we have. So what is abnormal uterine bleeding? So heavy menstrual bleeding is just a part of it. Okay, so what we thought is in the next few minutes we'll talk about some of the pathways between you and us. You know, what are the newer treatment, where does NICE comes in because we need a bit of regulation there, what service development we need. So anything in that color, service development bit, in my next 15 or 20 slides are relevant to you. So keep an eye open for that color there, okay? So how we can get primary care involved with us along with service development to prevent people not going into a hospital. So what are the patient side? And of course, we cannot talk in 2019 without cost. So what are the different types of abnormal uterine bleeding? So I looked at the last 31 referrals that came to me, okay? That's in 2 clinics. So heavy menstrual bleeding was 8 out of 31. Intermenstrual postcoital bleeding was 7 out of 31. Amenorrhea was minimal. So you can see, as it says, that 20% of all our gynae referrals are related to HMB. And also, one of the figures from your college says that 1 in 20 of your patients will have a gynae heavy menstrual menorrhagia sort of problem. It's just, again, it's very important before developing services to get a bit of the demography to see what you need. Okay, so what happens to the HMB? If you look on the left, right, they go mostly to a GOPD, outpatient. We have started since 2011 the one-stop hysteroscopy clinic. So we have done a service specification, it's there. I've again reviewed it about 18 months back. So it's there for you all to have a look and see if you can want to send patients there as well. But most at the moment comes through a GOPD. The second group of abnormal bleeding is, I won't talk about it today, is the postmenopausal bleeding, which is the real warrior, okay? They go to the 2-week clinic. We've got a fantastic pathway, the forms are there, and I think it's done very well. The third group of abnormal uterine bleeding is the intermenstrual and postcoital bleeding. So usually what I noted, if it's below the age of 35, they come to the general clinic. We rule out other things. If it's above 35 and persistent is the word I'm using, okay, then they should go to the Kolb clinic directly. I'll tell you what our figures of referrals were. So something like that makes it easier for the pathway and also good care for the patient. The amenorrhea goes to the general gynae clinic, as we do not have an infertility clinic, but they should ideally go to those. So these are the different types of AUB, abnormal uterine bleeding, that we look into and provide the service for. So we have the urgent pathways for the 2-week, which is well settled, and we have got the urgent pathway for the colposcopy. So all these indications you can see is lesion, the postcoital, more than 35 years, persistent bleeding, are going to the Kolb clinic. And recently we have seen that the patient don't have to go to gynae clinic and then go to Kolb clinic because your referrals are getting better and better. And I hope it follows that trend. The routine pathways are the HMB, the heavy menstrual bleeding. Under it, what it's got? The dysfunctional uterine bleeding, the fibroids, the polyp, and my biggest headache is the below 25 breakthrough bleeding. There's nothing we can do about this. So people on implant, depot, having breakthrough bleeding, and they are the younger group generation. I have not seen very much of them above 25, and that's really a big area where we need to deal with. In Barnsley, our waking times are pretty small, less than 6 weeks. I'll just give you a figure from 1st of January to 1st of May. We took 500 8 more referrals than last year. And that's come from all these areas. So I think we might be doing something good, or probably the nurses are giving them a lot of coffees and tea in the clinic, but I do not know. It seems that our referrals have gone up significantly. Another area of heavy menstrual bleeding I can't not mention is obesity. Obviously PCOS, obesity, PCOS, sometimes mingle is very important, is weight-related abnormal uterine bleeding. So we have seen the referral pattern in the last 6 months, just to give you an idea of people who are, that from 1st of January to 30th of June, in the outpatient we had 2,236. This is not heavy menstrual bleeding, this is all referral. I'm giving you the figure, 20% will be DUB. We have COLP going up gradually, and then of course the one-stop hysteroscopy clinic and also the 2-week clinic. So all these, as you can see, are going up gradually. I like to highlight the figure on your right on the low. So 54 of them, this is something important, had come to our outpatient clinic when after seeing them we had to upgrade them to 2-week. So this is where, to my colleagues, a plea, just keep a little bit note. It's nothing for me, nothing for you. But if this patient has something which has not been picked up within the timeline, then of course patient care. So I think this 54, which is a very small number, if you look at 3,000, is very small number, but I think it's important to keep. If there is any doubt, put a 2-week in, and we sometimes grade them anyway. So if in doubt. So the Royal College and Mori, we did a survey nationally for abnormal uterine bleeding, HMB, part of the abnormal uterine bleeding. And this was done once in 2005-06, and dysfunctional uterine bleeding was high, i.e. no fibroid, no polyp, no cancer, dysfunctional, hormonal. That has completely changed in the 2016 study. You can see that 50% of HMB had associated fibroid, polyp, or endometriosis. Do not know why the demographic changes is. Is it because our scans are very good that we are picking it up? I've got no idea. But the association has gone up significantly. And the second thing, again, remember in blue, 35% of them had no treatment in primary care. And I'm sure that if you have your colleagues here who would like to make sure that the referrals are appropriate, would like to look into this, aligning it with the NICE guidelines. So, I'll come to that. There are some simple measures you can think in your mind. It's very difficult for a general practitioner. I can see that. Easy for us. I know what my patients will be for the next 30. For you to have the mixed clientele sitting outside coming in sometimes causes the problem, and your time as well. But at the end of the day, I don't want you to be exposed to this situation. That's the whole idea we are here. So ensure that we do something to take these things away. So large fibroids are getting bigger, and another thing to think about is clinics in Marina. Who puts most of the Marina for menorrhagia in this area? Are there some surgeries? Sorry?
You do.
Yeah, that's what. Sorry, you, all right. I was just thinking, Look, because I was looking at some of the neighboring areas, and it's quite patchy, and as you can see, contraception is quite well. But for menorrhagia, it is not. It's nice to know then we can keep an eye on this and take this forward in future. So we have the urgent pathways, as I said, for the postmenopausal, postcoital. We don't want to talk much about it today, as long as you know that there is a pathway and we've got quite a system in place. We've increased this clinic by 20% in the last 1 year because of the demand. So let's come to the HMB. Okay, we know what the definition is. I can see 1/5 of all referrals are related to this. So you might have an idea with your practice size and demography, what is the expectation if you want a specialist nurse with gynae and etc. or developing something. So it's very, very important. Of course, there is an NHS cost as well, which is direct sometimes and indirect otherwise. So below the age of 60, 20% will have some sort of hysterectomy because of the heavy menstrual bleeding. Okay, the number of open hysterectomies and hysterectomies have reduced significantly since NICE guidelines of 2011 and the Mirena coil. So what would you do as a GP? I tell this is sometimes how my wife looks like, when she doesn't know what to do, comes home and asks me, that this is the problem we have. Very difficult situation. So what investigations we do and how you're going to streamline, because it's sometimes very vague, as I said. As long as you take a succinct history, two important things about the history is the smear history along with it, okay, and a quick family history. When will you do scan? Another thing we noted, we just did an audit. In the NICE guidelines, they said you need to do full blood count. Do you really need to do full blood count on everybody who comes with abnormal uterine bleeding? What is heavy? So I think it's sometimes I would use whenever you feel clinically that you need to, but doing routinely full blood count, I'm not very keen on it. Second is, who will you ask for scans? Okay, the ones which has got an incomplete examination, so either obese or you might find there's a mass, straight away goes for scan. And the third is treat for 4 to 6 months. So what I always say, if the cycle is regular, tranexamic acid, if cycle is irregular, hormones. I know some of you looking at me, in the NICE guidelines from last year, the latest, they said Mirena coil as a first stop. How many of you believe in putting a Mirena coil if somebody comes with menorrhagia in the primary care setup as a first thing? Do you really believe in that? I want to see. Okay, and if that works well, then we need to develop that service, because that's where the way forward is. Okay, at the end of the day, it is invasive. So at the moment, the working thing is, if the cycle is regular, tranexamic is cycle irregular, hormones. If not, and if they can want Mirena, go ahead with it. And if refer to secondary care, no relief after 4 to 6 months, of course, pelvic mass or abnormal scan suggesting a fibroid, polyp, etc. I think that's very important. So 2007, we don't want to even see this. It's moved on from there 10 years on. One thing what we have seen is, and this is again something you all need to understand, that because of the recommendation, and remember the findings of fibroid in 50%, the indication of hysteroscopy has gone up significantly. So on an average, from 5,000 hysteroscopies, it has gone up to 15,000. So in 3 times. So in our hospital, on an average, we have the service required for about 500 to 600 hysteroscopies for menorrhagia, not for 2-week clinics. So we've got quite a good service. But now we have to think that in the next 2-3 years, will it go up by 3 times? And that's a big commitment, because it's the service, the staff and the personnel, because not everybody can do. And hence, like Alison, okay, and throughout the country, will help us to actually support us in this. Second thing is, most of our cases, as you know, you all have got a contract with us which says that we should be offering local, and I think it's 65-35, and I think in the last audit did confirm to that the 65 of our hysteroscopies are done under local. So the 2018 update, okay, so when will you send it? Suspected fibroids, polyp, endometrial pathology, whether it's from history, examination or scan. Consider outpatient hysteroscopy. Does anyone of you see outpatient hysteroscopy being established in Barnsley in the next 12 months? 2 years? And I think this is something you need to look. But then I think it's like stealing from Paul to give it to Peter. You already have got service resources for other acute and chronic. How much can you do? So I think it's very important to deal with that. But I think that would be an ideal situation, is to do this outside the hospital. Changes to service will be needed, okay? And sometimes I think direct booking to hysteroscopy, again going by this little few things, pelvic mass above the age of 45, you can straight away send them for a direct clinic. This is the only nice recommended medical treatment for fibroids. Remember, I'm going back again, 50% will have fibroids with heavy menstrual bleeding. But it's so difficult. First of all, it's a red line drug, so it's only done in the hospital. And the amount of time the patient has to come in to get the liver function test, I'm moving away from it because I don't think, unless there is a service requirement, that we can actually accommodate these patients with a waiting time to come into hospital, but at the same time for the patient. So we have devised something differently, where the clinic staff are helping us to review the LFT along with the doctor who's there, and the prescription can be written straight away rather than waiting for an appointment from us. But I think Esmia is there to stay. The investigations routinely not recommended is the ferritin. Don't waste your money and time. Thyroid function, don't waste your money and time. They'll have other presentation than menorrhagia, okay? And the female hormones as well. Doesn't make any sense. Depends when you do in the cycle and what you do. So I don't think measuring estradiol will help anyone. We do not do MRI. That will be turned down anyway as a routine for this as a first line. Again, treatment not recommended is this luteal phase treatment. Day 14 to 28 or 26, danazol, and of course DNC. One thing I've just noted, last year and this year I had seen that some of our post-40s patient on long-time norethistone, and I picked up 3. One had her ischemic heart attack, a mild attack, 3 months after we stopped it. And it's very important that when people are on progestogen, keep an eye on norethistone. Norethistone is an androgenic progestogen, and it has effect on the cardiovascular system. So if you give them, and if we forget about them in the peri-40s, they might have a cardiovascular accident. So it's very important. NET is only for 3 to 6 months maximum in any condition. We do not give NET for long. It's just something which has come up because, as you know, the profile of women are also changing. They're getting more heart attacks, diabetes as well. So those days where it was sexist that men had more heart attack than women is not true. So in that age group, cardiovascular disease and norethistone is very important. So give them a softer progestogen. So when will you refer patient? Structural abnormality. And how would you suspect that? We have mentioned that before. Okay, so we do a hysteroscopy, which is a standard under local. They come, they have a hysteroscopy, and if things needs to be done there, we have again started for the last 2 years to actually treat them there. So what do you think would be the new clinical pathways for GP? Okay, the criteria is very rigid within 2018 NICE guidelines. We are trying to develop more see and treat clinics. Okay, we are doing polypectomy in outpatient, fibroid and ablation since 2016, 17, 18. And once we can get over the space is the biggest issue, we think we're going to start doing this even more. The medical options are still there, okay, but the failure rate is quite high and it's pretty expensive as well. So choosing the patient at the first time and then having a management plan actually saves all of us a lot of problem cost-wise and quality-wise. So conservative surgical, we are doing all this under local in outpatient. So we'll show you some of the, so this is the lights, can you see it? There's some endometrial polyp, so we just sit down there. It's like anywhere else, like the colonoscopy and polypectomy is something very, very similar. You can see little polyps, we remove them, it goes for biopsy, it's done, and we can put the Mirena coil at the same time. So we really don't need to. Another question I need to ask you, how many of you bring your patients back for coil check for Mirena for menorrhagia? None. Good. That's That's a very good thing. Because I've seen some of my junior doctors coming from Sheffield always say, go and see your GP. And I say, I'm going to ban you from the clinic if you put that, because that's what they've learned somewhere else. We do not. Self-check for them is the best thing. Why do you need to bring them up for someone to check the Mirena coil? So it's very important we can actually do that all at the same time. Is it twice? So this is an idea of how the new procedure is done. It's basically a fancy scope which has got something like a shaver, the same thing that the arthroscopy, if you see, use, something very, very similar. Sorry. Yeah, there you go. Something very similar, okay? It's got a shaver in, it goes in, you remove. And the important thing, and this is a health issue, all my colleagues 5 years back around the country or 7 years back was removing polyp. So you come, you see a polyp, you come out, you put a forceps in, remove the polyp, got no idea whether the polyp was removed. You're sending this for biopsies, at-risk patients, obese, diabetes, and PCOS patient, and we didn't know what was coming. But now we do it under direct vision. And I think it changes quite a lot. That if these women come back, it's a new pathology. Because I'm sure, when I did that 10 years back, that when they came back, it was the old pathology, because something has been left behind which you have no idea about. Is it downloading this one, Alison?
I think I saw it.
Do it twice. Okay, yeah. I think the light's showing. So this is a polyp. So once you start shaving it, and it sucks it in, so you get the histology, it's gone. Okay? And it's reassuring for the patient as well when we tell them that we've got some histology and it's normal. Especially in the peri-40s and 50s, I think this is very reassuring. So you mentioned about treatment for heavy menstrual bleeding. We don't do any more balloon ablation. We don't do any more microwave. The new two things are come, and we are doing it in Barnsley in outpatient under local, and our feedback is very good actually. So we are a bit reticent of doing this in the first 6 months, but then when we spoke to patients and all, I think the demand has gone higher. So you can see on the right bottom is what it looks like. It's like the lining has been cooked. Okay, you must take biopsy before that, so if there is any hidden pathology, you do not miss them. Very important quality issue for this patient. So why outpatient? We all know that, it's simple thing, and especially, for here, that is very important that we think about in future about the relocation of care. So could you have that, like continence, we could have some services in the primary care, as you're already doing, things. So you have the coil, you're doing a pipple biopsy, you're putting the Mirena coil, okay. Why can't we move into hysteroscopy and etc. And I think it's good for the patient and it will be cost effective as well. So the modern services probably will look something like this, which is diagnostic hysteroscopy, operative hysteroscopy, and I think we have developed all this in your local hospital over the last 5 years. So all of this is available in Barnsley as an outpatient service. The cost benefit, so the day case, £6 versus outpatient. The outpatient, when we looked at the postcode, most people who drove, because the car park issue, or 2 buses came to that. Okay, in outpatient it was a longer because they came twice to be dropped in and taken back. So it's good for the patient. And look at it for the hospital as well. Your tariff is better in outpatient, where I need 1.5 nurse, And in theatre, you have 5.5 nurses, somebody admitting you, it's a mayhem. Why do you need to see all these people in theatre in a modern day? Okay, and for us, I think the cost effective is very, very good. So it's important for the hospital to understand that and make sure it's good for the patient. So we mentioned about the services that we already are doing, and we will see how we can move on from there. One thing what we realized looking at the last 6 months figure is that our referral rate to these clinics are going up, both from Barnsley and from neighboring unit. Hysterectomy, last option. I don't think at the moment, before somebody takes a decision of hysterectomy, they're seen in secondary care, though often we get requests from my colleagues in primary care, patient washes with hysterectomy. You know that with the clinical governance issue. Not only that, it's not necessary. We don't just do hysterectomy because somebody wishes, okay? So that's one thing. One of the things what we find, I do not know, sharing with you, is reticent to use Mirena coil. They decline Mirena coil. It's like the Marmite, yes or no business. So some will expect it. So giving a little bit more time, especially from our colleagues, if you prime them a little bit, it becomes easier for us. But if you don't prime them and say, go and see so and you will get a hysterectomy, it becomes very difficult for us. So I think we work together on this, okay? And I think we remember that, okay? So basically, to conclude, we have some pathway changes to do. Okay, we are looking at the monitoring, the referrals. Most of them are very good. We have got 4 VTSs in our hospital in Gynae, and in 20 years, I think 80 GPs probably are prescribing and doing well because they've gone through a system of knowing what a good referral is, and I think that's very important. Okay, close monitoring from the CCG perspective as well, qualitative and quantitative. And what are the roles of GPs? As I say, big role, not only the GPs, the specialist nurses with them, big role, but at the moment with manpower, it's a big issue. But I think that should be our aim in future. OPD, operative, we have done most of this thing for the reason that's been already mentioned, cost and quality, 2 important things. And the role of someone like Alison, nurse hysteroscopist, she'll be there to educate if anybody needs any help, any of the nurses in the clinics to learn, she'll be quite happy to support and develop those things. She does quite a good educational thing to the VTS trainees about management of menorrhagia. So again, telling them when they're developing their practice before they become a full GP. So I think it's very important. NICE is always on our head, but it will be there, but we have to do what we have to do. So the way forward is probably the pathway. Who are the main players and where it should be done? Inappropriate referral, I do not know what the word means. Can somebody explain to me what inappropriate referral means? Do you have a referral management center here at Barnsley, John? No? Okay. So, most of you try your best. You seen a patient, you did what is your best, and you referred on, we do it. So what is inappropriate referral? I find it something difficult. Probably some of them is more an educational thing, But how you can stop it? The only way is to write an educational letter. I think 2 lines into it is the best thing to do it. I think we have developed this service which is called advice. Okay. And so it's sometimes very difficult, because at midnight someone, but we try to do as much as possible through the advice and say, why not move forward? Probably a virtual clinic would be the best thing where you sit in front of a computer for 2 hours and you get all the questions and you answer them. Could be a day forward, I do not know. A lot of my junior colleagues are very savvy with their media, the phones, this, that. I think it's a way forward. So hopefully, we'll get a happy person and a happy patient to go home. Campaign. There are 2 campaigns. Again, as I said, I live with 3 women at home and I work with millions. One of these, wear white again. I didn't know that till I was part of a campaign, that how many people actually, and this survey was done from all the big shops and the online, that how many people do not want to wear white because of the uncertainty of having a period, heavy. So This is a big campaign, I think. Wear white again, where you have the confidence. It's a bit like incontinence. If you're on the M40 at 10 o'clock in the morning, and if you have got, what do? You look for the where the service station on your phone first, something like that. So it's something very important to close to my heart, that people who have got in 2020 that freedom to actually wear what they want, and I think it's very important. We should be part of it. Thank you very much. I'll stop here. Is there any questions?
Can I just ask, we see a lot of fibroids on scans. Which are the fibroids that you're interested in seeing?
First of all, the ones that are symptomatic and anything more than 3 centimeters. Okay. Because less than 3 centimeters, if you are putting marina and everything in a biopsy, is fine. And also, it's very important is, if you look at the fibroids, it grows in the wall, then it either comes into the room cavity or goes out. If it goes out, mostly it stays there. If I take a scan and go to High Street and start scanning, first of all, I'll be beaten up. And second is, 1/3 of my patients will have fibroids. What do you do with it? Nothing. So the ones more than 3 centimeters and symptomatic needs to be dealt with.
When you say symptomatic, you don't mean the bleeding. That you
Correct, yeah. I'll give you one example, good point. I recently did a hysterectomy on someone whose fibroid weighed 2.5 kilograms. Okay, so 5 years back she was my patient, and I gave her the choice. I won't say what the postcode of the patient is, sorry. Okay, so said, fine, I'm going to go to Sheffield, fine. She went for embolization, I never saw her again. And then she came back to me sometimes in middle of April. So fine, I saw her, continuity of care, good. I said, so what happened to you 5 years back? You went to Sheffield and they went to do embolization. They said, no, you stopped your periods, you're 52, go home. That's fine. I went home, but she didn't realize that now she has the right hydronephrosis and the kidneys 60% gone and the left. So she went. So pressure symptoms in large fibroids is important. So don't think about that period is the only problem for fibroids. Second, in my little lifetime here, we have three sarcomas in fibroid. Below the age of 55, because that's the time when it is very nasty. So it's very important for large fibroid, just thinking about period is not the only issue. It's very, very important to remember that, because all the books that were written about changes in fibroid to sarcoma were written in 1950, because nobody did any survey after that you won't have hysterectomy, you will have. And it's very important for large fibroid growing, especially postmenopausal, is important to have a second check and the patient have an option. Thank you.
So, but scan should be suggestive for both sarcoma and obstructive growth.
Scan can't pick up a sarcoma. MRI can suggest, but it's too late already. I'm talking about.
That's where your 3 centimeters.
Yes, not that. I'm say a 7 centimeter fibroid, you're sitting on it. Just mention to the patient about the changes as well. Okay, and if the fibroid grows, anything that grows above 50, I don't like it. Other than hair.
Interval scan. Do you do an interval scan?
We don't do anything. We tell the patient because we do not have the service to follow.
Expect us to be.
Yes. So if the patient said, if you want, it's more than 6 centimeters, we'll do 2 scans. If it's growing, we'll refer you and then we can have a chat.
Less than 3 centimeter one.
Less than 3 centimeter, chances are minuscule. Thank you very much. I'll stop here. Thank you.